And this is something that if you represent a progressive group, your group can sign on to. But we'll talk about more of that at the end. But yes, as Amar mentioned, we'll be talking about public health and the pandemic today. The COVID pandemic has really highlighted the importance of creating a robust and well-funded public health system and the shortcomings of our own existing public health system at both the state and federal levels and municipal levels in some instances. So this evening, we're going to be examining the strengths and weaknesses of our public health system and what changes we can make to protect us from pandemics such as this one, and also to look at some international examples for comparison. There are countries that do it better than we do. We're going to start with two presentations, and then I'll open the floor to questions. And I ask that everybody sort of hold their questions until we've heard from both speakers, and then we'll just open it up and have an open discussion. So our first speaker tonight is going to be Dr. Natalia Lenos, who is an epidemiologist and expert in both US and global public health. She's currently the executive director at the Harvard University FXB Center for Health and Human Rights, and previously she worked at the United Nations Development Program. She's also, I just learned tonight, has been involved with New York City Health and Hospitals Corporation, and so knows quite a bit what went on in the ground there, which was sort of ground zero for our epidemic to some extent. And she'll be, Dr. Les will be providing us with a general introduction to the public health system and some international examples, racial disparities, and sort of setting that stage for us. And then our second speaker tonight will be Massachusetts Representative Lindsay Sabadosa, who represents the 1st Hampshire District. And Representative Sabadosa is a lifelong activist and organizer and a champion for healthcare in the State House. In fact, she introduced the Massachusetts Improved Medicare for All bill long before the current pandemic. She's been on this fight, and she'll be focusing on public health from a legislative perspective. And as I mentioned, I'm Dr. Louise Parker. Feel free to call me Louise. And I am a healthcare policy researcher, educator, and activist, and I'll be moderating for you tonight. And now I'd like to just turn the virtual floor over to our first speaker, and that will be Dr. Lenos.
Thank you so much, Louise, and please call me Natalia, everyone. It's really wonderful to join you tonight. I am a social epidemiologist, and maybe a year ago, people on this call would not know what an epidemiologist is, but sadly, we all do today. Epidemiologists look at patterns of disease distribution and try to explain what are the reasons, not for why one individual, but why different populations are getting COVID or other diseases, heart disease, diabetes, or are dying at younger ages than others. So my perspective, I have a doctor in front of my name, but I'm not a medical doctor. And I think that's an important first point to start on, the difference between public health and healthcare. So we know that the US spends more on healthcare compared to any other country in the world. I think last year's figure was around 3.8 trillion. That's about 18% of our GDP. And that is a significant amount more than our other peer kind of wealthy countries. Other countries spend half that, but yet in the US, we have worse health outcomes. We have shorter life expectancy. We have higher rates of a range of diseases. And as Louise mentioned, this has also meant that in the US right now, 2.5 million people globally have died of COVID, 500,000 have been Americans. And that in many ways doesn't make sense. We have some of the best doctors, some of the best emergency response people. We are a wealthy country. So why is that? So today I'm going to talk a little bit broadly about public health, then delve into COVID, and then think about the future. What does it mean to prepare for pandemics? I hope to do that in 10 minutes, but I'd love to, have conversations on any of the issues that pique your curiosity. And because I did work at the UN, I grew up in Greece, so I'm used to a different healthcare system, one where universal health coverage is kind of the norm. I'm going to throw in some international examples. So in terms of, what is public health? For a social epidemiologist like myself, public health is pretty much everything that shapes our lives. It's our schools, it's our workplaces, it's our environment, it's our water. It's basically where we live, where we play. Is it healthy? And yet we spend very, very little of that 3.8 trillion on making our neighborhoods healthy. One estimate is that for every dollar that the US spends on treatment, on healthcare, about 2.5 to 3 cents go to public health. And if you take out from that the amount that goes to sort of substance use and misuse, that drops to between 1 cent to 2 cents. So very, very little. Our public health infrastructure has been historically underfunded and continues to be underfunded. And the irony is that when public health is working well, it's invisible to us. And it's moments like these, moments like a global pandemic, where we sort of wake up and say, oh my gosh, why are we only spending, 2 cents on the dollar within our healthcare on public health? And the hope for many people in public health right now is that, the public will demand that we do better. And so I want to say that public health spending is not the only thing we should think about. In fact, some data shows that social spending on education, spending on unemployment, spending on other safety nets is a better predictor of life expectancy if you're comparing countries than just healthcare spending. So while this conversation is on public health, for a social epidemiologist like myself, that might not be the same for infectious disease epidemiologists or others. I want to spread the umbrella bigger and include public health interventions to include, education, unemployment benefits, housing, really critically important. So, just want to make sure that I'm using the term public health pretty broadly, environmental, climate, all of that. And to echo sort of what Amar said, that, we spend so much on sort of protecting ourselves from war and, building up our military, and we significantly underspend on that social spending side. So what went wrong with COVID? In March of last year, when we had the first death, the director of the FXB Center and I, her name is Mary Bassett. If you don't know her, she was the New York City Health Commissioner before she took on the role at Harvard. We wrote a piece and we basically said that our underlying and deep-seated social and economic inequalities were likely to create unique vulnerabilities here. We were talking about racial inequities as well as economic inequities, and also that the current political climate, we were writing at a time of a Trump administration. We highlighted low trust in institutions, skepticism, and even disdain for science, and the expansion of sort of the anti-immigration policies and post-truth narratives were basically creating a recipe for disaster. We said that when there had been one US death, and we basically called out a warning. We said, unless the US takes a very explicit health equity lens to responding to COVID, we were in trouble. And the title of the piece that was in the Washington Post was, the US is at risk of having the worst epidemic among wealthy nations. And we said that because we knew that our country has underinvested in public health, that we have a true problem in terms of the number of people who are uninsured, the fact that we do not offer universal health coverage. And also we knew that the social determinants of health, our inequities in terms of racial inequities, the fact that we have deep poverty and segregation in terms of neighborhoods and underinvestment on all these fronts, that they were going to cause challenges that, unless they were front and center, they would result in an unequal as well as higher level of morbidity and mortality. And, when we were writing the piece, there had only been one US death. We sort of asked each other, like, are we exaggerating? Are we causing panic? In retrospect, obviously we weren't. And what we're seeing now with the vaccine rollout is that those inequities are still happening. And we are a year into this. And that's something that, during our Q&A, I want to delve into the whys and the hows, and why are we not protecting our workers? Why don't we have sick leave? Why did we not put in place some of the measures? So let me jump to what other countries did. Countries like Taiwan. I should mention that their vice president at the time is an epidemiologist, and who immediately put in place measures. They put in place some pretty stringent measures on quarantine, but they also put in place measures of testing and other sort of public health measures. What's important to note is that all of us across the globe have similar tools. The core tools to dealing with an epidemic are contact tracing, testing, then contact tracing, health education, wash your hands. But the structure, the funding, the efficiency, what we prioritize, and how we roll these out has varied, and that has meant different people have succeeded in different ways. What Taiwan did right, and what we saw other countries like Denmark do right, is that they didn't only say, this is what we need to do, they also provided people with the means to follow public health advice. So I remember, and many of you probably remember, in early March, I am, privileged enough to have the money to buy 2 weeks worth of food. I have little, I had at the time, my twins were still in diapers, to buy, a month's supply of diapers, to stay home to work. But staying home, following public health advice is a privilege that not everybody could face. And if Gladys Vega was here today, she would say Chelsea experienced, the high rates, not because people were ignoring public health. It's because we did not provide the means for people to follow public health guidance. We did not give people sick leave. We did not provide people money. We did not, do everything that an epidemiologist or a public health professional would say we need to do. We only focused on the technocratic, wash your hands, quarantine, test. And we also failed on all of that. South Korea, the number of tests South Korea was doing compared to the US is, 10 times more at times. Like, we simply failed on making testing available, affordable, spread out. Countries like New Zealand have been highlighted as being, and Jacinda Ardern, the Prime Minister of New Zealand, as being able to be a tremendous communicator. Finland too, they talked about communication, and even Germany, the ability to sort of say the truth, talk to the public, recognizing that, we didn't know a lot and that the science was constantly changing, but yet build faith in institutions. So when you underinvest in institutions, when you attack science like Trump did, no wonder today, an accounting of what has happened in the last year, there have been 180 state and local public health leaders across 38 states that have either resigned, retired, or been fired since the beginning of the pandemic. And that is the largest exodus of public health leaders in US history. So we are at a moment of reckoning of, we not only were facing the biggest pandemic, we were not only poorly prepared, but now we are actually not well prepared for the future. So let me switch to the future. What should the future look like for public health preparedness? I'm someone who entered the climate space kind of late, in my adulthood. But if we think about COVID, it's, what scientists call a zoonotic disease. It's about how we have treated our environment, how we have, built our cities and basically created opportunities for humans to interact with animals in ways that isn't, typical, whether it's because we're, livelihoods are in different countries, people have to go out into sort of, areas that are rural, or it's how we build houses, how we're not really thinking about urban planning. All of that, Ebola was a zoonotic disease, and obviously COVID is too. Interestingly, I mentioned Ebola because although many African countries, including, Rwanda, Liberia, spend, a fraction of what we spend in healthcare and don't have the public health systems in place, I think there has been a lot of learning, and they did put in place tremendous measures. Every supermarket had, running water outside so you could wash your hands going in and out. Every, airport controls, everything. So we have actually seen countries across Africa do really well with COVID. So I wanted to sort of highlight that spending is one dimension that, I talk about, but that's not really what makes efficient public health. Efficient public health relies on trust, on communication, on people putting in place policies. So what does the future hold? First, we do hope in the public health community that this is a wake-up call, that people will invest at every level, at the local level. Boards of health in Massachusetts, should have been at the forefront of the vaccine rollout, and somehow they haven't been, and I'm really looking forward to Representative Sabadosa's, discussion about what Massachusetts has done. But, we have to invest resources, people, and rebuild, because it has been a real tragedy. But we need to be proactive, thinking about climate change as the next but real challenge, but also the more boring things, tobacco control, or making our neighborhoods more walkable, because unfortunately epidemics capture our media sort of attention, but what is killing most Americans on an average year are the silent killers, the chronic diseases, the non-communicable diseases. And that's where public health can cheaply make a difference. In New York City at the health department, it was things like putting in place trans fat bans or salt labels, or changing the laws as to where and who can smoke, or how much you tax alcohol. So there's a lot that public health can do for cheap, but requires public support. I'm going to end there. I hope I sort of covered a lot of different things, and I hope that was enough to sort of whet your appetite and ask me any questions on New York City to, internationally. I lived in Lebanon for many years. So anywhere and I grew up in Greece. So any sort of questions, global, local, I'm very excited for this conversation. Thank you so much, Louise.
Thank you. That was wonderful. And I'm sure appetites are very wet and people are going to be having wonderful questions. I know I found that all fascinating. So I'd like to now turn to Lindsay Sabadosa, who will talk from a legislative perspective, and then we will open up the floor. But thank you, Lindsay.
Thank you so much, Louise and Natalia. I found that very interesting. It was like Public Health 101. So thank you for doing that, because I think I was going to start off and talk about what our boards of health used to be and what we used to think of our boards of health as. But I think I'm going to say, first of all, one of the things that struck me about all the information that you just shared is you were naming countries. And when we talk about what Germany did or what Korea did, we can't really ever say what the US did, because we don't know what the US did, because the US does not act as the United States. We act as states, individual states that have all taken their own approach to COVID. And I think we're worse for the wear. And that's why we're seeing such high levels of COVID, such high numbers of deaths in this country. And our boards of health, I think I always thought of these as places that ran flu clinics and talked about mosquito control, quite honestly. And let's see, the opioid crisis, which our local boards of health have pulled together and tried to address in interesting and creative ways here in Northampton and the surrounding communities. But this idea of centralized versus decentralized is, I think, what has been at play throughout the entire pandemic. And it has hurt us because we have never picked a real path forward. So initially, we started off with testing and contact tracing. We knew that a vaccine was coming. I will express huge amounts of frustration that we didn't prepare better for this vaccine to be coming, but we started off with the testing, and it became immediately apparent that the state was going to try to sort of take this decentralized, centralized approach to testing and throw testing up in different places, but without really understanding the local communities, because they weren't asking. That's where legislators come in. We tend to be very vocal advocates for our local communities. And we talked a lot about why there wasn't adequate access to testing. But because our public health infrastructure has been starved, I think, in the state of Massachusetts for such a long time, there was no one to say at DPH, that site that you just put up, there's no transportation to it. Do you know how many people would actually go to a site? I'm going to keep referencing Western Mass in this talk, a site in Holyoke, because people reference different cities in different ways. People in Franklin County won't drive down that way. People in Hampden County will only drive west instead of east. Those are things that the local boards of health knew, that people in our local communities knew. And if we had been communicating earlier on, we could have solved some of those problems. And yet we've encountered consistent and regular pushback from the Baker administration, really at every step of the way. So moving on to contact tracing, we heard a lot how we were going to have robust contact tracing. And initially that did sort of stem through the boards of health. But what happened was that different smaller communities were asked to work together. And then you had boards of health doing contact tracing, and then you had a large company brought in to do contact tracing. They weren't allowed to communicate in all the necessary ways. And so we find, even today, we resolved, I think about 2 weeks ago now, a case in one of my communities, West Hampton. They share a board of health nurse. They're a consortium of 6 tiny communities in the hill towns. And they were finding that because they share a zip code with another larger city, all of their cases were getting sent to that city. The city was immediately sending them to the state-run contact tracing, and they weren't finding out for weeks and weeks and weeks who had COVID in their community. Now, what does that mean? That means they can't tell the school committee what the cases really look like. They can't tell people in the community because they know best who interacts with whom. The contact tracing company is backlogged, and so people weren't even getting that initial call, all while there was a public health nurse sitting there waiting to trace cases. It's just a really good example of what happens when you try to take this hyper-centralized system and push it onto your local boards of health. And we're seeing this again with the vaccines, this ping pong between local boards of health are going to issue vaccines. They're going to get, first of all, 100 doses a week. That's what we're told. Then they're going to get 300 doses. That goes to nothing. The next week it's announced, nope, all of those doses are going to mass vaccination sites. So the level of frustration is very high. And I think our local boards of health feel a deep level of distrust with the state of Massachusetts at this point, and they have every right to feel that. Many of them are trying to regionalize in order to keep some of those vaccine doses. But we have to, I want to stress that these are the places that understand what the dynamics are in different communities. So for example, right down the road, we have Springfield. Springfield is the asthma capital of the United States, not of Massachusetts, of the United States. At the same time as we're trying to fight COVID, we're trying to fight a biomass plant that they're trying to put into that city, which would exacerbate asthma rates, in addition to causing increased pollution when you have tons of trucks moving into the city every day, bringing in wood to burn. Asthma is not put on the list of comorbidities, and no one is having the conversation. If we really want to reduce rates and increase health in this city, then we need to be fighting this on two different fronts. There's a complete and total division between what the state thinks is fighting COVID and what our local boards of health think are fighting COVID. And I think that as we move forward, it's going to take more investment in public health. And I loved how Natalia said, public health is something that you don't see if it's working well. But we know that we need to make those investments. So there is legislation that can do that. There's SAFI 2.0, which is HD 1712, and I can put that information in the chat. It's a great piece of legislation that would require standardization among boards of health. It would require proper funding, and it's backed by the boards of health themselves. Now, I always say that Medicare for All is actually the great public health investment, because it takes all that money that we're currently putting into our healthcare system and it gives it back to us. It frees up funds. And that's money that we should be investing into public health, into social determinants of health. I am having a hard time telling you about all the bills that we should have passed to actually effectively have dealt with COVID, because sadly, we haven't passed them. If it had been up to me, and I think many others in the legislature, we would have paid people to stay home. When we hear about other countries and how they were able to lock down and kids are able to be back in school, it's because they pay people to stay home and to do what's safe. It's because people have those options, but we haven't passed emergency paid sick time here. We haven't increased unemployment benefits the way they need to be. We haven't just met basic expenses. When the pandemic started in Massachusetts, a lot of really good bills were filed. And personally, I filed this little package of bills that I thought were really important, a lot of them having to do with housing and congregate care, and how do we make sure we're not spreading disease in places where people can't separate. The unfortunate truth is that none of those bills are passing because all of those bills are very expensive and we just don't want to make the investments that we need to do. But I think that there is some silver lining from the federal government, which feels odd to say, given that we have at times felt very, very, very abandoned by them. You know, there are regulations that would allow us to take people who are living in shelter right now and move them into non-congregate settings. But we're finding that the state of Massachusetts isn't really interested. And I think we're not really interested, and I say we because as a government official, we're all complicit in this. We're not interested because it means that once the pandemic ends, we're going to have to figure out how to keep that level of investment up. The federal government is only paying for it for a short period of time. But I think that those are the type of things that we're going to need to have people pushing back against. They're tiny, they're hard to identify, but once we find something like, why are we not using those FEMA dollars to put people in hotels? I'm sure, I don't know where everybody on this call lives, but I'm sure if you went to your downtown, there are people who are sleeping outside tonight, because that's pretty much every community in Massachusetts. And while a lot of those people may be shelter adverse, they don't necessarily want to be on the street. So that would make our community safer in the first place. It would help stop the spread of a disease that we know we need to stop the spread of. And I think that there are points that we can rally around that are not necessarily just the larger pieces of legislation, they're in addition to the larger pieces of legislation.
Great. Well, thank you so much. Boy, these were both so interesting and giving me lots of fuel for thought. I really appreciate this. Um, I'm seeing lots of interesting things happening in the chat, but I'd like to open this up to questions, and people who have been putting some of those interesting things in chats. I hope that you will pose a question and get this into discussion. I know both our speakers are anxious to have this dialogue with everybody here. And I am not able to see everybody on the screen at once just by the nature of there's so many people here, which is really wonderful. So if you would like to ask a question, I ask that you just type in the chat question or speak or whatever you like, just some little one worder in the chat, and you get to the chat by going to the bottom of the screen. I know all of you are Zoom experts by now, but just in case someone is, and if you go to the bottom of the screen, there'll be a little a thing that looks like a cartoon bubble, and you just click chat, and then there you go. Wonderful. Okay, I am already seeing the questions piling in. So just give me 1 second so I can get to the top there. So Michael, would you please ask your question? And if you'd like to aim it to one speaker, feel free to do that. Or if you want to ask both of them, that's okay too.
Hi, I'd like to address both speakers, Dr. Linos and Representative Sabadosa. Rep Sabadosa, you already touched on something I was going to ask about, which was the fact that we, unlike other countries, didn't essentially pay people to stay home. So you essentially already made that point. I wondered if you could talk a bit, so I'll two questions here, basically. I wondered if you could talk a bit more about being able to acquire the funding needed for those sort of measures. And my second question, which this is aimed a bit more at Dr. Linos, is me after Trump left office was when the current leader of the CDC said vaccinating teachers was not a priority, which is just absolutely insane. And that's the kind of thing I would have expected from an official in the Trump administration. A lot of us, held our nose and voted for Biden, hoping at least we'd get a better COVID response. So my question there is, like, what are your thoughts on holding our public health leaders accountable? Because they screw up. They're of course subject to these political and pressures and so forth, like almost any other government official. How do we make sure we hold their feet to the fire when we might get this blowback of, oh well, you're just like the Trump people, you're denying science, you're etc., when we know that's not the case? So those are my two questions. Thank you.
Natalia, do you want to start, or would you like me to?
I'm happy to start with that second question. And obviously the teachers in school question is really top of mind for everyone, including electeds. It's really a big one. So let me start by saying I'm a parent of 3 kids. My 7-year-old is in 2nd grade in the public schools here in Brookline, and my twins go to daycare full time. Your question is about vaccine prioritization. I think schools are such an essential part of our, just being able to function as a society, both for the education, the mental health of the kids, but also not most importantly, but importantly as a working mom, for women to be able to stay in the workforce. So they serve a purpose way beyond, just just educating kids. They're critical in my mind. And, I have joined parents who say, schools before bars, like, why is Massachusetts allowing indoor dining when schools aren't open? Like, how have we not prioritized schools? So I am with you in terms of prioritizing safety and schools and making sure they're safe. Now, the question of vaccines is really complicated. There's many who argue that age should be the top priority because, when you're 75 and above, your risk of dying is significantly higher than everybody else. But age is a problem in many ways because, first of all, if we were to use just the age cutoff, 90% of white Americans would be vaccinated, but only 50 of those who have died in COVID, because the vast majority of white Americans who die are dying above the age of 75. But many, many Latinx, Black, and Indigenous Americans are dying at much younger ages, 30, 40, 50. So age does not seem to independently make sense. Teachers is the same question. Like, most teachers are relatively healthy, so chances of them getting sick is high because they're in schools, but the chances of them dying, some public health experts are saying, are pretty low. In fact, meatpacking district, people who are working in grocery stores. So there has been a big debate of where do essential workers come vis-a-vis age. And, I'm sure Representative Sabadosa can speak to that. I don't think the vaccine prioritization is so clear cut. I personally would like to see teachers vaccinated because of the broader role that schools play, but I don't think that they would be top of mind if dying was our main criteria, who is most likely to die. So I hope I answered your question. And I think that's the challenge. Public health, we want science to be neutral, but science is political. And I don't know how many of you know this, like, I ran for Congress because of COVID, because I felt that more scientists should be stepping in, because I felt that we should be at the table in the conversations around, recovery, and why more money wasn't going from the federal level to the local level, because I was seeing that the impasse was happening at that level. And, and so I do believe that scientists should be stepping into political spaces, because these aren't easy trade-offs, but we have to be honest that these are trade-offs, and there are trade-offs on education and on health and on gender and on women staying home. And I'll pass it to you, Representative Sabadosa.
I appreciate that you went first on that, because I think you added some perspective that's helpful. I will say, there's so much frustration about the way the vaccine has been rolled out, and I think, we started with health professionals, and I think that there are very few of us who would say, oh, health professionals shouldn't have received the vaccine. But what we know to actually be true is that health professionals received the vaccine, and people who worked in the back office received the vaccine, and people who don't see patients received the vaccine, and people who worked remotely also received the vaccine, because we left it up to the employer to sort of determine who was getting that dose. And then, we moved through the different categories. And I think one of the greatest frustrations with teachers and with workers is that they've been moved down the list. And so when we talk about the initial days of COVID, when we were shutting things down, and the signs that people put in their yards, and the great statements they made about supporting our grocery store workers and our teachers and our firefighters, we've broken that list up now, and we've kind of said, sure, but after people who are 75 plus, and after people who are 65 plus. And I think that it made a great deal of sense to go through congregate care first. I think we do not talk enough about what a disaster COVID has been in our nursing homes, the number of deaths, and what a terrible job we did managing that. So that made a lot of sense. It makes less sense to me, and I could be wrong about this. I am not a public health professional, and I am not a physician, but it makes less sense to me that we are working to make sure people are vaccinated who have every ability to stay home. And then we're asking other people to go out and to work every day. And I put teachers high on that list. I put restaurant workers very high on that list, though, I have to say, because we're doing indoor dining. I go down, I do not dine indoors. I will freely admit to everyone. But when I see the size of our restaurants and the way people are working in these small cramped spaces, and then they are in these small cramped spaces with people who are dining indoors who are taking their masks off, they don't have a choice. And they don't have a choice because, frankly, their unemployment has run out, and their unemployment wasn't very good to start with anyway because they're tipped workers, and they're all there trying to survive. So I think that in the prioritization, we also have to take some of those things into consideration, because while it is very true we don't want more people dying of COVID, it is shattering every time I find out another person in my district has passed away. We also need to protect the people who are just trying to get by, and we're not. And where does that funding come from? I mean, that's sadly the story of the United States, right? Like, all of this gets thrown on the states to manage, but at the same time, the funding has to come from the federal government because the states have to have balanced budgets. Now, could we do creative things? We probably could. We could probably bond. We could probably, figure out ways to get money to come into the state, but no one is doing that. No one is interested in doing that because it's not how we've ever acted, and we aren't interested in figuring that out during a pandemic. So we rely on the federal government to fund us. And as I think you've all seen, that funding is not coming through at the levels we need.
Hey, thank you. Those were wonderful answers. Next question comes from Asma.
Hello, everyone. My name is Asma, and it's not as much a question as a comment or personal experience. I'm a physician in the state of Massachusetts, and I work in Cambridge area. And my focus of work is essentially in the nursing homes. Since March of 2020 to date, the number of deaths we have seen and the lack of direction we have had from the Department of Public Health, and the lack of support we have had from the Department of Public Health is mind-boggling. It just makes you wonder. That's the authority figure we reach out to every week. We meet with the Department of Public Health to get the direction, the regulations, the sort of hand-holding to get us through this time of crisis. And what happens is they came very strong in the beginning as support, but now instead of supporting, the sentiment is more of punitive nature, because more and more regulations are being set to reprimand you now, as opposed to let's figure this out. This is a problem we all are dealing, and let's help us out in this situation. And so that was one personal experience. And the second one, just what Lindsay just said, I was in a store yesterday and I was wearing my hospital vest, which had my name on it. So there was another customer in the store. She reached out to me and she thanked me for what I do just because she read my name. And out of curiosity, I asked her, so what do you do? And she said, I'm a teacher in one of the school districts of Massachusetts. And I asked her, have you been vaccinated yet? And she said, no. And she works with she's a special ed teacher. She works with children with special needs. And she started just telling me story after story. And we were in the store for good about 25 minutes. Just I'm hearing her out, how frustrated she was with the lack of support and from her own administration, from the state of Massachusetts. She herself had written letters to Governor Baker expressing her fear, her anxiety for her being exposed, cross-contaminating, and just creating more vector for the spread of the disease. So it was an eye-opener and another level. We just see our side, like healthcare needs support and healthcare needs funding and vaccination and whatnot. But like you said, there's a whole segment of the community which is completely being neglected. So I just wanted to share that.
Thank you for sharing, Asma. And I just want to say that, we are grateful for the frontline healthcare workers because, and I'm going to jump, Louise, because somebody did ask a question earlier about the World Health Organization calling for global equity on the COVID vaccine. And I want to say that what they're asking for is trivial. They're saying, can we have 3% vaccination rates in our countries to cover our healthcare workers, our essential healthcare workers? I'm hearing from friends in South Africa and other countries who are losing, like the top doctors on those countries. And these countries already have such a thin kind of, in terms of the number of, some countries have like one mental health professional for an entire, city. If that person dies, you're putting at risk the entire healthcare system. So I am completely with the World Health Organization in saying that, at a minimum, we need to vaccinate every country's essential healthcare workers. I think that, will not deal with the real deep inequities that we're going to see between wealthy countries and not wealthy countries, but wealthy countries, it is in our interest to not allow other countries to completely lose their entire health and public health infrastructure. But that question also talked about intellectual property rules. And, the elephant in the room is that we are dealing with prioritization and trying to see who goes first because we simply do not have enough vaccine. And why we don't have enough vaccine is partially because, we just now got to it. But right now we have so many different types of vaccines. So we could lift some of the intellectual property rights. We could force or encourage others to produce more. And we're seeing countries like China and Russia developing their own vaccines and using that as vaccine diplomacy. The US is so hesitant to step into that, intellectual property conversation that we're not doing it. And that is a question, a bigger question. And I would side with, it is such a priority. We need to vaccinate the whole world. And we're, if we're talking about 3% of other countries by the summer, that puts everyone at risk, including the US, because of the mutations we're seeing, because, we can't shut down our countries, we can't shut down trade and tourism. So I just wanted to touch on that because of Asma's comment. It just reminded me, sorry, I went backwards, Louise.
That's totally fine. I actually, she didn't put herself in the chat to ask a question, but she did have posed that earlier. I had her on my list, and that was Anna Barreto who had put in the chat about that issue. I just want to make sure, and thank you so much for bringing it up because I had it on my list because I thought it was so important to discuss. But Anna, was there anything in addition that you would like either Natalia or Lindsay to address in terms of global vaccine distribution and equity and so forth? Or was that covered in the last comment from Natalia? Anna there. Speak up. Or you can chat to me in the comment if there's anything else you'd like to ask. Why don't we wait? She'll let me know if there's anything else. But in the meantime, Timothy had a question.
Yeah, I actually have a number of questions, but they can be summarized perhaps most succinctly as I have, despite considerable effort over the last year, been completely unable to ascertain what the Surgeon General and their army of apparently 6,500 uniformed, full-time Public Health Service Commission officers have actually been doing during the pandemic, when they're supposedly on call 24 hours a day, ready to be deployed at a moment's notice around the world, no less, to stave off public health emergencies. So you can read about this. It seems to be official, but the press has been so totally silent about it. Everywhere I've looked has been totally silent about it. It's almost as if they're sort of just a plaque on the wall, but nothing more. They're soaking up a lot of money, though. What's going on?
I don't know. And now, and it's, yeah, I'm going to look into it. I didn't know that there was a 6,500, uniformed health. I mean,
Just
I know
go read
that
Wikipedia.
Yeah, I mean, I know that there are uniformed, like I know the CDC has like an epidemiology cadre and they do wear uniform, but they're actually people like me who do research behind a desk in
Those
uniform.
are volunteers too. They're
But,
not full-time professionals being paid
okay.
for this.
No, but I'm saying that the CDC has kind of a cadre of epidemiologists, but they actually just do research. They're not doing frontline work, but I want to look into it and I will, and I apologize for not knowing. If somebody else on the call does know, or I mean, Representative Sabadosa, maybe you don't.
No, I have absolutely no idea.
Yeah. But it's a good question. Although 6,500, if I don't know if it sounds like a big number, but it's not such a huge number. If we're thinking about the New York City Health Department has itself several thousand public health workers, and many of them are nurses in schools, so 6,500 is maybe enough for one or two cities. It's not a huge number.
But there's a volunteer.
The volunteer cadre, yeah.
They could go out and organize and collect volunteers. I mean, they're a considerable force, and they're supposed to know exactly how to deal with these situations and mobilize the resources needed. That's what they're there for.
And globally,
and I mean, around the world.
Yeah, and globally, the example of community health workers, there have been models of, who is the right person to be going out. I had a graduate student at Harvard whose parents were in China at the beginning of the pandemic, and she said they were in their house, and there was a community health worker who would drop off groceries every day. They were not allowed to leave the house. They were under quarantine, but there was a community healthcare worker who would drop off food.
You seem to be missing my point. I'm not saying that this Public Health Service Commission should go out and take the place of community volunteers. I'm saying they should go out and organize those community volunteers, recruit more of them, and basically do what needs to be done. There's a lot of resources out there that could be recruited that don't cost a lot of money, but they need organizers. These people are supposed to know how to organize. That's what a lot of public health is, in fact. So once again, I'm mystified.
Okay, well, thanks for that. Our next question is from Arya Avakian. Go ahead, please. Sarah still with us? Oh, I see she is there. You're mute. If you could unmute yourself.
I want to come back to him or her.
Okay, yeah, let's go to Jana Galberson, please.
Hi, I'm a doctor at a community health center in Springfield, and the first thing I just wanted to say was a comment that I was surprised it took so long to sign up for a vaccine by phone. And there's a huge digital divide, and it was just so impossible. Like, I had trouble going on the website, and my patients just couldn't do it. And it's a huge relief to be able to tell people to call 211 now. So, thank you, Lindsay, if you were involved with that. The other thing is that we have one big mega site here at the Eastfield Mall. But there's a few things, like one, our patients, first, it's hard to get people to trust the vaccine. And after we have that conversation, they ask if they could get it at the health center. They feel more comfortable getting things at the health center. The other is that the transportation's an issue for people that are disabled or have mental health issues and are a little bit afraid of public transportation. I mean, there's just so many issues why it's difficult to get to the Eastfield Mall. So we got a little bit of vaccine from Bay State, and so we've been having Saturday clinics, but it's only been for 75 and up, and we kind of finished that. So I had two questions. I was curious, one, if the community health centers would be getting more of a supply, even the ones that aren't standalone, like Caring Health Center in Springfield, but also the Bay State affiliated. I work at Mason Square. And the other, I had heard that Springfield Housing was getting a supply to give to residents, which I think is great, but I also was curious if it would go to people in the surrounding neighborhoods, because access is really key, and the housing themselves are kind of small, but if it was a site for the neighborhood, that would be better too. So that's it. Thanks.
So a couple things. So the vaccines are coming back to the hospitals. That was announced this morning. So that's really, really good news. We don't know in what amount it was. We're suffering a little bit of whiplash because we were told last week that all of a sudden none of the hospitals were going to get vaccines anymore. And then this morning, out of the blue, after many, many angry, tense, teary emails, we were told, nope, they're coming back. So we're very happy about that. I know Bay State is very much on top of this and has been advocating really hard, and we hope that that will mean that they go out to the community health centers as well. The administration has said that they really do want to prioritize vaccines going to community health centers because they recognize the role that they play in this. Now, they say that, and yet that doesn't seem to actually be the case when we look at what's happening on the ground. So I think it's important that we stay in communication so we can say, great, you've prioritized this. Can you explain what that means? Like, does that mean you're sending 100 doses or 300 doses or 1,000 doses, like a whole box of Pfizer? But that we just don't know the answers to that yet. And I think one of the most frustrating things, although the list is very long, so it's hard to use the word most, but one of the frustrating things about this whole process is that we tend to find out decisions about an hour before they are announced publicly without all of the necessary details to share information. And I know that that's true for you too, and I know that's true for our local boards of health, and apparently it's even true for the companies that, write the software to make the appointments. They're not told either that things are happening. So I think we will stay in touch and we'll figure out what is happening, but that is a huge point of advocacy for a lot of us. So for affordable housing and senior housing, the plan has always been for those vaccines to be administered on site. And because we were trying to figure out how the minds of the Baker administration works, we found out that they were talking to directors of these sites a few weeks ago and telling them that they needed a plan in place. It is not for the community, though. It's really only for the people who live there. They're kind of considering them, it's obviously not congregate care, but I know I've certainly heard from everyone who lives in our housing authority, we share the same elevators, we share the same laundry room. There is no space, there is no distancing, unless you stay in your apartment and don't leave. So I think that your point is well taken, because that would really get the vaccine into communities and it could really help with vaccine hesitancy. I'm frustrated about Springfield and Holyoke in particular. I see Boston trying really hard to get public health officials out into the community and talking about that the vaccine is safe and doing that word of mouth communication that really does need to happen. It can't just be a press conference with the governor. That doesn't inspire faith in people to put something into their arm when they don't actually know what it contains. So I feel like that's really been missing out here. And we see it in the numbers of who's getting vaccinated. And vaccine hesitancy is really huge, though, just right across the state. And I think we see that every time a new phase opens. You sort of realize that we hit that like 45%, just under 50 mark. Then all of a sudden the floodgates open and we have 1 million people who are angrily trying to call. I appreciate that 211 is working. I've also had really negative feedback about it. So it's good to hear that it's been helpful for your patients.
I just want to say one other thing. It's not perfect, but the websites are just impossible because a lot of people don't have smartphones. They have old Obama flip phones or whatever. Yep. But the other thing I found with vaccine hesitancy that I don't think is getting out enough is that even though we call it Operation Warp Speed, the technology for the vaccine has been in development for a few decades. And I think when I talk to people and they say, no, this isn't brand new, it wasn't just like done in months and you're being experimented on, it's something that has been in development in labs for years. And I could see like a lot of times that just creates this huge sense of relief, like that this is, people have really done detailed work on it, so.
Right.
Yeah, that's an excellent point, Jana. When I first heard about the vaccine development and they said they're going to get it out as quickly as they did, I said, no vaccine has been developed that quickly. And then when I learned, well, actually what this was, that the science behind it, then yes, they could do it because this is not a new vaccine at all. But I think the public's really confused. That's a really good point. And it's sort of, how do you get that information out there? Jess had a question.
Hi, yes, thank you. Hi, I'm Jess. I had a question and it was mainly, actually it's for both of you. I wonder what you know about the accountability. Even though this system of local versus state versus federal has definitely shown that we have a very broken system, it does seem to be the path that we're on. And I've recognized that in many cases, corporate partners are being funded by FEMA and state health departments in order to distribute the vaccine. And it's kind of being placed in their hands by states and by FEMA. And I just wonder what you know about the accountability that's in place to ensure that they're doing it safely, what they're doing for their workers, that they're abiding by the distribution mechanisms and rules that the state has put forward, and what we can do to influence that accountability and make sure that the vaccines are being distributed equitably and reasonably.
Do you mind if I start on this one?
Please.
Okay. I have a lot to say about CVS and Walgreens. So one of the initial problems with the way the vaccine rollout happened in the state, particularly for the 75 plus category, so when we were starting to open a little bit more to the general public, is that the Trump administration had an agreement where a certain percentage of all of our vaccines, a percentage, went to CVS and Walgreens, which turned out to be terrible because they are actually not particularly great at getting those vaccines out the door. Now, I will tell you, there are some rural communities where they rely on CVS and Walgreens or Big Y or Stop and Shop or whatever like local sort of pharmacy it is. I hear way better things about the grocery stores because they have the space. CVS really doesn't. But that was a disaster. So a lot of like the initial problem was figuring out how do we take those doses from these places that the federal government has promised a vaccine and move it to places that are better at actually getting it into people's arms. So all of that said, there's been a lot of redistribution. The state is monitoring doses in a much more careful way right now. So if you don't use it, it comes right back to the state and it gets redistributed to somewhere else, so they can't just sit on it. The problem that we're finding, and Natalia might be able to answer this, or someone else might be able to explain this to me because I don't really understand. What we hear all the time is that they never know how many doses are in a vial. And so CVS and Walgreens have been really good at just like handing it out to people who show up at the end of the day. And that has led to issues with people not getting their second appointments because they don't want to say that they've taken on these other people who don't match what they've reported to the state that they're handing out. Even though our boards of health do that too, but they're better at reporting it. So accountability. DPH fundamentally is in charge of making sure that Walgreens and CVS and your Big Ys and your Stop and Shops and whatever other grocery stores you have in Eastern Massachusetts are monitoring what they're are following what the rules are and what they're supposed to be doing. On a practical level, I think, as you've kind of heard from this call, DPH is overwhelmed and swamped. And so it's a little bit like whack-a-mole. We get a call from a constituent who tells us that there's a problem at a particular location. We elevate it to DPH, and then we solve that problem on a one-to-one basis. But there's no great... At this point, the Secretary of Health and Human Services is doing 16 different jobs. Everyone on her staff is doing 20 different jobs. And there is no monitoring of everything that's happening, like on a real, as you would hope for, level. So it is truly people like me who hear from a constituent something is wrong, who are making sure that CVS is accountable. I do now have the names and phone numbers of all of their intergovernmental affairs people, though. So there's that. Still not the best system.
Yeah, I don't have much to add other than to say that, there's been sort of a push towards, Governor Baker to just go faster and faster. And so I think that the whiplash that you spoke about, Lindsay, of, one day they take it from the hospitals and they put it at the big sites, is trying every minute is like recognizing, oh, now we have to think about transportation. And so the CVS Walgreens is, I guess, supposed to be convenient. And so convenience and making sure that people can get there faster. But I don't think, given the number of mistakes that are happening, I don't think accountability is top of mind. It's like, are they just getting it out? Like, are they recording it in a way? And it'll be the afterthought and thinking backwards is like, how could we have done better? But unfortunately, decisions seem to be taken at, very rapid speed, which I understand. And actually, Lindsay, I was going to ask you, you talked about, the housing authorities getting the vaccines in sight. Has the same conversation happened for teachers? And Michael, I think you misunderstood me. I really think teachers should be vaccinated for more than the risk that they face. But I would love to hear if there was a plan for vaccines for teachers to happen in schools. That makes the most sense in my mind. You show up, but I had asked someone about 3 weeks ago, and they said, no, there's no plan yet as to how we're going to vaccinate teachers. Do you know if there's a plan now?
There's not a formal plan at this point. There were some ideas around testing in schools and pilot programs for that. I think that there are the same sort of plans in the works for vaccinations in schools, but nothing concrete right now. And I've said this to every teacher who's written to me. It's almost like the administration has a personal vendetta against teachers. Everything that they ask for, from vaccines to canceling MCAS, because dear Lord, our kids are like learning on computers and just not ready to take standardized tests. It's been a no right up and down. So, but I do think that said that there will be some sort of program. And I do know as well that there is a list of larger employers who have offered to host vaccination clinics. They're not at the point yet where they're allowing them to do that because we simply don't have the number of vaccines required. But if you have more than 100 employees and you want to host a clinic, the state is taking names and numbers. So I think that will happen at schools. We're just not there yet. And you'll find out 30 minutes after I do when it happens.
That's great. We've gone through all the people put themselves in the chat, but there was some discussion further up in the chat, which I've been reading as it rolls by me, and about and it's following from something that our two speakers have been talking about and alluding to, is sort of the chaos that this has all been, in the chaos and how this is being delivered, and nobody really knows the rules. And somebody had said in the chat, well, until we have a universal health delivery system with some, and I'm paraphrasing now, it's not exactly the words, but a sort of more rational universal healthcare system, how can we possibly even do this? And I'm wondering what you both think are the roles of that sort of the health delivery system, and how important would it be to have a more universal organized plan system, such as we see in the United Kingdom, or as opposed to in Canada, what we have is it's not a universal health delivery system, but it is a universal payment system, versus the public health system, and how those all integrate and what roles they have in managing pandemics.
Do you want me to jump in first, Lindsay? I mean, I'm obviously a big proponent of Medicare for All, and I think that if we had an NHS, we would have a list. We would know who our 75 plus people are. And rather than relying on them to go online to find an appointment, we could just call them and schedule it. Like, this kind of asking people to figure it out is a real problem, because many people, first of all, can't figure it out because they don't have the literacy, the access to a computer, the young person to help them. They might not know that they're eligible, like literally not be aware that they fit the criteria. And so we're creating all these barriers, and then we add hesitancy on top of it. And I wanted to mention that because hesitancy came up. Hesitancy is an issue of why we're seeing, Black, white, and Latinx, like lower rates for some communities, but access is a huger issue. The fact that you actually don't, you have to travel really far. You might not have the means to, put your brother or your kid to spend 3 days to get you an appointment. Like, access is really also a huge barrier, and the two intersect. If you're going to have to spend 20 hours and you're already a little hesitant, are you really going to do it? So just saying that, and now I lost my train of thought where I was going with this, because I went on to the side note. Lindsay, save me and I'll come back.
Sure. Well, I was appreciating everything that you were saying. So, I filed a state level bill for Medicare for All that would be within the state of Massachusetts. And I spent a lot of time thinking about how it could improve our current system. And I think some of the things, even though it's a payer system, it is not a system that dictates, where you get healthcare or how you get healthcare. it would, there's a huge focus within the legislation about equity and about making sure that not only are we paying for services, but we're paying for places where services are provided. And so there are communities in this state that don't have the healthcare infrastructure that they need. And when you when you create, as the legislation does, a board of, I don't want to say a board of health, that's not the right word, a trust, a healthcare trust, there we go. A healthcare trust that would have representation from across the state, as well as public health. And we talked about long-term care and representatives from all those different groups. We can figure out how to better respond to crises, because you already have that infrastructure. It's not there to provide health care. Again, it's there to figure out the payment, but it supports all of that infrastructure. And then when you need it, as Natalia, I think, really beautifully said, you know who the patients are who are over 75, and you know how to reach out to them. One of the greatest issues that we have is this whole question of comorbidities. 75 plus are people with 2 comorbidities. Nobody knows what that means. Nobody knows if they qualify. The CDC says one thing, Massachusetts says another thing. Your doctor may say something different. It's fundamentally flawed because we don't have any sort of centralized system that's helping us through this. And I think that Medicare for All is one of the solutions. It's not the panacea, it's not the magic wand. I like to say magic wand, but it gets us a lot closer to where we need to be.
Yeah, and let me add that the 2 comorbidities thing is confusing, and it's especially difficult for people who don't have access to, who are uninsured. So you haven't gone to the doctor. You don't know if you have the comorbidities. You have no, I mean, I know that in Massachusetts, you don't require documentation, but you might not even be aware of your comorbidities if you haven't been to the doctor for the last 5 years because you're uninsured or underinsured. So it's definitely widening inequities in some ways. But I want to, about it not being the magic wand, I started my presentation about the difference between healthcare and public health and how little money goes into public health, and really thinking about public health in that broader sense of our environment, our healthy neighborhoods, our workplaces. And I fully support it, but a future pandemic won't be prevented if we have universal health coverage. If we don't address climate change, if we don't address some of these big challenges, we will have more and more pandemics. So we might be better at treating, but treatment is definitely much more costly than prevention.
Well, I wanted to thank her. I don't see any more questions. I want to thank our speakers, but along the lines of what everybody has been talking about in terms of the health delivery system, there are some and I want to give you some action items to take away from you. Actually, before I do that, I just want to make sure, do our speakers have anything additional that they'd like to share with us before we roll out and I deliver my action items to the group? Anything?
Just to thank you for the invitation, and also, if Lindsay, Representative Sabadosa, I definitely want to engage with you more and just, say that, the FXB Center for Health and Human Rights is an academic institution, but we want to be making sure that the research actually reaches people. And I think that divide is really one that needs to be bridged better too. Not the failure of all these really good public health schools in Boston and Massachusetts that have not served our people is one that we also have to admit to. And this is an offer to you that reach out if you need any help from us.
Thank you so much. I will echo that as well. I thank you, Louise. Thank you, Natalia, and everyone for this evening. I've learned a lot, which is always a sign of a good conversation if everybody is learning at the same time. So thank you.
Well, I once again want to thank our speakers. This has been a wonderful discussion. You have provided really useful information, and also to everybody here who asked a question or wrote something in the chat. You contributed to making this more richer and more interesting. And along those lines, there are a couple things I'd like to bring up. One is several bills that I encourage everybody to call your reps to get them to co-sponsor them. Here in Massachusetts, most people here are from Massachusetts, please call your state representative to co-sponsor Representative Sabadosa's Medicare for All bill, which is now HD 2656. This is not the first time she's introduced this. but let's make this the time that it actually gets to the floor for a vote and it's passed. And that will only happen if we demand it and let our reps know we are outraged. So please share your outrage with them. Also, there is a companion bill. It has to go through both houses, and that's Senator Ellenrich's Medicare bill, and that's for the Senate side of it, and that's SD 546. There are also several other bills, and Omar will post a letter. This is related to that in the chat. This is a letter from Mass Peace Action that talks about going back to the original theme of healthcare, that we should be funding healthcare, not warfare, but also many other things. And as Natalia and Lindsay both brought up very clearly, that when we think about healthcare, really more broadly, it's also about housing. It's about access to food. It's about education. It's about many things. We can't be healthy if we can't. It's about the environment, of course. Global warming is very frightening and is going to increase our exposure to pandemics like this one. So there are many things there. So for those of you who are representing some organization here, we'd love to have you sign on to this letter, and it is now in the chat, so you can link onto that and take a look at that. And it also mentions some other bills in there that we'd love for people to also reach out to their senators and representatives about, which are the Massachusetts Coalition for Health Equity, Guaranteed for Housing, and the Safe Communities Act, which is trying to provide safe harbor for our immigrants. So Omar, I just want to turn to you to see if there's anything left that we want to share with everybody before we let them go to the rest of their evenings.
No, thank you so much, Louise, and thank you to both of our speakers. Thank you to everyone for participating, for viewing the chat. Yeah, so Louise talked a little bit about this healthcare not warfare statement that we've drafted. As we heard tonight, we heard so much about our disjointed public health system in the state and issues with vaccine delivery and vaccine supply. And somebody asked a question, where is the money going to come from to fix all this? And Representative Sabadosa said, well, it's got to come from the federal government. Well, the federal government is spending so much on the Pentagon budget, and we have so much money there where it can be used to fund all this. So before we sign off real quickly, I'm just going to share my screen here. I just want to show this letter that Louise brought up. This is our healthcare not warfare sign-on letter. It's addressed to both state and federal representatives. We have a quote here from President Eisenhower about the military-industrial complex. I'm not going to read the whole letter, but this opening statement just talks about how bloated the Pentagon budget is and how 30% of our state budget comes from the federal government, roughly 30%. So what we're asking of our state and federal representatives is, as Louise mentioned, to pass the SAFE 2.0 Act for our public health infrastructure, the Guaranteed Housing Stability Act, the Safe Communities Act. We're asking for our state legislatures to increase the tax rates on corporations and high-income individuals to fund all of this so that we don't have to cut our local social services. To our federal representatives, we're asking for a $300 to $350 billion Pentagon budget cut. This was proposed by Mass Representatives Jim McGovern, Ayanna Pressley, and others, including Barbara Lee, who's been a leader in this field. We're asking for a federal repeal of the 1033 program, which sends military hardware to our local police departments. We saw much of that in the aftermath of the murder of George Floyd with this hyper-militarized police response. We're asking for a single-payer healthcare system, both within the state, which Representative Sabadosa has been leading on, and she introduced the bill on, and also the federal bills. And lastly, we're asking for a Green New Deal because the environment impacts our health and our public health. So on that note, I think I just want to say once again to everyone, thank you so much for joining us tonight. Massachusetts Peace Action has a Healthcare Not Warfare Committee. If anybody's wanting to participate and work further on these issues, they're welcome to join. I'll be sending a follow-up email tomorrow with the recording of this event and also with some of these action items we presented. So everyone will have my email address. You can write to me if you'd like to participate more with Mass Peace Action. And on that note, thanks again, and everyone have a great night.
Thank you all very much. Bye-bye.